So if you are new to this channel, I am Dr. Himadri. In our pediatric simplified lecture series, today we'll be talking about asthma. This is the second part of our video. So, so what are the clinical features of asthma? Look here, we have already discussed that is cough. Cough, there is some specific characteristic features of this cough, that this is nocturnal as well as it is usually present in the early morning and it is usually of dry cough, and there is breathing difficulty and chest tightness. And look here, there is a bilateral polyphonic wheeze which you can auscultate, and also there is excellent response to the bronchodilator and maybe ICS, that is your inhalational corticosteroid. But the most important thing is that there is excellent response to bronchodilators. And number 5 is that personal or family history suggestive of atopy like allergic rhinitis, eczema, all that. So this 5 symptom complex is very important for diagnosing asthma. So you must also understand what are the pointers that will tell that this is not asthma. Like if the cough is chronic and also this is wet in nature, that is sputum or that is productive cough, this is not asthma. If there is a high grade fever, it suggests that there is some infection, this is not asthma. And also if there is unilateral localized clinical features and also unilateral localized wheeze, this is not asthma. Asthma is always bilateral. And if there is poor response to bronchodilator therapy, this is also not asthma. So you must remember this 5 symptom complex and also where to tell that this is not asthma. Okay. And another thing is that in the history you must take the history of some comorbid conditions which are very common in asthma, like allergic rhinitis. This is seen in 80% cases. So there is association in 80% cases. And secondly, obesity, and if there is obesity, of course we have obstructive sleep apnea that may be present. And also GERD, that is gastroesophageal reflux disease. And there is adenoid hypertrophy. Okay, so after these clinical features, how will you actually diagnose? So I have already discussed the 5 cardinal clinical features that are important for diagnosis. Apart from clinical features, we do have some tests. The most important test is your spirometry. So this is our spirometer and this is the mouthpiece, and usually the children more than 6 years can actually do this test. And in this test we have, look here, the through the mouthpiece the child is supposed to expire the air forcefully. So this is the expiration curve, and in the expiration, and this is the inspiration curve that you can see. So look here, during expiration the child will basically do the expiration, and there is FEV1, that is forced expiratory volume 1. 1 means in 1 second how much amount of air the child can forcefully expire out in 1 second is the FEV1. This is the most important thing, and this is going to be reduced. And how it is being reduced? Look here, this is the airway caliber during inspiration and this is during expiration. During expiration normally the caliber of the airway is going to be reduced, but in asthma there is chronic inflammation as well as edema. Therefore during expiration the airway is further narrowed. Therefore the air cannot come out during expiration fully, leading to this obstructive pattern. This is characteristic of asthma. So look here, during expiration there is scalloping or coving, and there is significant reduction in FEV1. FEV1 is your forced expiratory volume in first second. Okay, and this is the curve. And after giving bronchodilator therapy, there is excellent response. Therefore, the curve is basically increasing here. Look here. So you can remember like that. Okay. So when you are doing spirometry, what is called as positive diagnostic test as per GINA 2024 guideline, you have to do the baseline FEV1, and after that we have to give salbutamol. Though the dose is 200 to 400 microgram, and you need to wait for 10 to 15 minutes and for it to work. After that, once again you have to measure the FEV1, and if the FEV1 is improved by more than equal to 12%, this is diagnostic of asthma. Another investigation you can of course do is chest x-ray. Usually chest x-ray may be normal, and another thing is that hyperinflation, because of during expiration there is obstruction, therefore hyperinflation you can understand. So another diagnostic test is your peak expiratory flowmetry, which is called as peak flowmetry. This is the peak flow meter through which the baby is supposed to expire, and during expiration the maximum value, that is we have to do it for 3 times, and the maximum out of it we have to take. So another diagnostic test is your peak flowmetry. Peak flowmetry is mainly used for your monitoring purposes. Look, we can use it for diagnostic purpose as well, where spirometry is not available or the age of the child is less than 6 years. In that cases, you have to do the baseline PEF, and also 200 to 400 microgram of salbutamol should be given. You have to wait for 10 to 15 minutes, and after that repeat the PEF, and if there is improvement in PEF for more than or equal to 15% from the baseline, we can take it as positive test. Okay, but mainly we actually use it for monitoring purposes, like we measure it in the morning hours as well as in the night hours, that is in the evening hours, and also this is written in the diary, and from here we actually monitor the disease activity. That is, we have given the treatment, the child is responding or not, we actually monitor through it. So some asthma pharmacotherapy options that are used as per GINA 2024 guideline. Look here, we have controller. And what is controller? Controller means that can control the recent symptoms as well as it can prevent the future attacks. And the example is SABA, short-acting beta agonist with ICS, inhalational corticosteroid, or LAVA, that is long-acting beta 2 agonist with ICS, inhalational corticosteroid. We have another drugs, like group of drugs like relievers. Relievers, they treat the acute symptoms only. Examples are SABA, short-acting beta agonist, as well as MART, which is maintenance and reliever therapy. We have another thing like AIR, anti-inflammatory reliever. They are taken before the exercise to prevent the symptoms. And the example is MART. Once again, MART is your maintenance or reliever therapy. You know, the MART here is basically the king in our management of asthma. It can control the recent symptoms as well as the future attacks. So this is a typical example of MART, maintenance and reliever therapy, Foracort, which contains formoterol as well as budesonide. Budesonide is your inhalational corticosteroid. And this is a picture of MDI, meter dose inhaler, of levosalbutamol, which is SABA, short-acting beta-2 agonist. For asthma pharmacotherapy options, let's look here. This is our bronchial smooth muscle, and your goal of treatment is to leads to bronchodilation. How you can achieve that? You can do via this beta 2 receptor. If you give some drug which is basically agonist of beta 2, it will lead to bronchodilation. As well as there are muscarinic acetylcholine receptors. If there is antagonism, that is inhibition through this receptor, it will also lead to bronchodilation. So the beta 2 agonist drugs are your salbutamol, levosalbutamol, terbutaline. These are SABA, short-acting beta 2 agonist. As well as we have LAVA, that is long-acting beta 2 agonist like salmoterol and formoterol. Okay, and also look here, these are your antagonistic drugs in the muscarinic acetylcholine receptor. These are SAMA, that is your short-acting muscarinic antagonist like ipratropium or LAMA, that is long-acting muscarinic antagonist, which is your tiotropium bromide, like that. Okay, we do have some other drugs which could be used in asthma, like LTB4 antagonist, which is leukotriene B4 receptor antagonist, montelukast, zafirlukast. We have some biologics here, that is monoclonal antibodies, anti-IgE antibodies, omalizumab. We have anti-interleukin 4 receptor antibodies, which is dupilumab, and also interleukin 5 antibody, which is mepolizumab. Okay, so in 6 to 11 years children, the treatment options for asthma is basically done stepwise. So what is step 1 of management of asthma? If the symptoms, we have already discussed the symptom complexes, if the symptoms are persisting less than 2 days per week, we call it step 1. Okay, in step 1 management, as a controller and also reliever, what you will be doing, you will be giving the ICS, inhalational corticosteroid, and SABA, short-acting beta 2 agonist. At the same time, when there is exacerbation of symptoms, you will be giving that, and also eventually you will taper it off. Okay, so what is step 2 management? If the symptoms are persisting for 2 to 5 days per week, this is step 2. In the step 2, you have to give the controller medication, that is inhalational corticosteroid low dose ICS, which should be continued, and it is usually given for 3 months. And as a reliever, you have to give SABA, short-acting beta 2 agonist, as needed. That is, when there is symptom, you have to give it and eventually gradually taper it off. So what is step 3? Suppose the symptoms are present most days per week, or if there is night waking, even a single day of night waking is present, we call it step 3. So there is or, remember that. And the treatment as a controller is your daily low dose ICS. So we have low dose ICS here also, and also in step 3 low dose ICS plus LABA, that is long acting beta 2 agonist as a controller, and as a reliever is SABA, short acting beta 2 agonist. So in the controller we can use another thing which is called as your MART. I have already told you, and the dose for MART is your very low dose, and actually MART contains daily very low dose of ICS as well as formoterol combination. Okay, so you can use MART here, and also as a reliever MART also. Okay, and also look here in the step 4. What is step 4 management? Suppose if there is daily symptoms plus night waking. So the difference between 3 and 4 is that in the 3 there is or, but in case of 4 there is daily symptoms plus night waking at least one day per week, at least 1 day per week or more than that. So here the treatment is daily medium dose ICS plus LAVA, long acting beta 2 agonist, or so here the treatment is daily medium dose inhalational corticosteroid plus LAVA, long acting beta 2 agonist. Okay, or we have MART, but we have to use the low dose MART here. Remember in step 3 we have very low dose MART, in the step 4 we have low dose MART, and here the daily low dose ICS plus LAVA, here medium dose ICS plus LAVA, and also reliever is same SAVA or MART. If you are using MART here, you have to use MART as a reliever. If you are using this combination, you have to use SAVA as a reliever. Okay, so what is step 5 management? Step 5 means all the features of step 4 plus exacerbated symptoms which are not being controlled with appropriate management. So this is step 5. In step 5 you have to use daily high dose ICS with LAVA plus minus biologics that we have discussed, that is mepolizumab, dupilumab and all that, and as a reliever you have to use SABA. So again the same treatment here we gonna simplify it. So in step 1 what we will be doing, you have to get levolin plus budecort only at the time when there is symptoms, and after that you have to gradually taper it off. So levolin means levosalbutamol, and budecort is your budesonide, that is your inhalational corticosteroid. Okay, and also in the step 2 what we will be giving, we will be giving your budecort. Budecort, that is ICS, should be given for at least 3 months, and also during exacerbated symptoms you have to give levolin. Levolin is your SABA. Okay, and in step 3, step 3 we have to give MART, and MART is the most important treatment strategy here, and the dose is 1 puff once daily, Foracort, which contains 100 by 6. 6 your formoterol and 100 is your budecort. Okay, and plus 1 dose or one puff as needed. And in the step 4 you have to use the MART once again, but the dose is 1 puff daily, BD dose plus 1 as needed. Okay, remember that in step 3 and step 4 you have to use MART, and maximum dose for inhalation per day could be 8 if there is exacerbated symptoms. Okay, and in step 5 remember we have high dose ICS plus LAVA combination and plus minus oral corticosteroid, and here you can give oral corticosteroid plus minus biologics, and you have to refer to the specialist. So once you have given the treatment for asthma in children 6 to 11 years, now you have to reassess this patient after 1 month. Okay, and in the follow-up you have to ask for 4 questions. Number 1, daytime asthma symptoms for more than twice per week, that is at least 3 or more than 3, any night waking due to this asthma symptoms, and also use of SABA as a reliever for control of these symptoms for more than twice per week. And number 3, any activity limitation, like because of the symptoms the patient cannot walk, cannot run, cannot swim and all that. And these 4 questions you have to ask, and you need to know it is yes or not, and after that you need to classify it. Well controlled asthma means none of these are positive, none of these are present, and partially controlled means 1 to 2, and also uncontrolled asthma means 3 to 4 out of these followings are present. So therefore, and look here, if it is a well controlled asthma you need to step down the treatment, and in case of partially controlled and uncontrolled asthma you need to step up the treatment. That is our protocol. So remember here, more than twice, that is at least 3 or more than 3, at least 3 or more than 3. SABA as a SABA use as well as daytime symptoms. Okay. So we have talked about the inhalational corticosteroid, low dose, and low dose is 100 to 200 microgram daily, and medium dose is 200 to 400 microgram daily dose, and also more than 400 microgram is the high dose for our inhalational corticosteroid. Okay. Now the treatment options up to 5 years. We have discussed 6 to 11 years. Now we will be talking about up to 5 years. How will you manage? Step 1 treatment is same. You have to use the inhalational corticosteroid as well as SABA and when needed. And after the symptoms, that is you have to taper it up, let's say within 1 week or 10 days. And after that, this is stopped. And in step 2 treatment, you have to continue the inhalational corticosteroid as low dose for at least 3 months. And the SABA is given when there is exacerbated symptoms, and eventually you have to taper it off like the same. But in step 3 we have to use a double dose inhalational corticosteroid. That is usually this is that is the medium dose. Okay, so here it is low dose, this is double the dose of ICS for at least 3 months and SABA. But in case of step 4 management, remember we have to use the double dosed ICS plus this is a scenario where you have to refer the patient to the pulmonologist. So in up to 5 years we don't have step 5. This is the difference. We don't have step 5 till step 4 we are having, and step 4 is the maximum and when you have to refer. And from step 2 onwards you can add a leukotriene B4 antagonist like montelukast. Okay. So how will you follow up this? Once again, after 1 month you have to follow up, and there you have to ask for 4 questions the same. But remember here daytime asthma symptoms for more than equal to twice, that is more than once per week. And here any activity limitation and use of SABA as a reliever, that is more than once per week, that is at least 2 or more than 2. Okay, so the difference is 3 and here is 2. Okay, and also any nighttime waking and also any activity limitations. These 4 questions and same categorization. If it is well controlled, just step down, and if partially controlled or uncontrolled, you have to step up the treatment. That's all. So once again revise, we have completed it. So in the clinical features there are 5 symptoms, rather 5 symptom complexes like cough and chest difficult and also chest tightness and breathing difficulties, bilateral polyphonic wheeze, and excellent response to the bronchodilator, personal or family history of atopy. These are the pointers you have to know. And the comorbid conditions like allergic rhinitis, obesity, GERD, adenoid hypertrophy, like that. And for diagnosis, apart from clinical features, you have spirometry for the confirmation, and you know the FEV1 will be reduced, and the FEV1 after giving salbutamol will be improved by more than equal to 12%. This is diagnostic. And also you can use peak flowmetry, but remember in PEF the value is more than equal to 15% improvement. And here the therapy options we do have here, and this is your Foracort, this is Levolin, and you know what is SABA, LABA, what is SAMA and LAMA we have discussed. And apart from this we have leukotriene B4 antagonists like montelukast and other biologics like that. And also this is the treatment option, step 1, 2, 3, 4, 5 for 6 to 11 years, but for and this is 6 to 11 years, and you know that treatment options as well as the doses here. And here you have to follow up for 6 to 11 years, and this is the dose for your low dose, medium dose and high dose inhalational corticosteroid. And this is our treatment options till 5 years. Remember one thing, we don't have step 5 in up to 5 years. Here we have till step 4. Okay, and this is the follow up up to 5 years. The questions are same, only the difference is this is more than equal to 2 and that was more than equal to 3 in case of 6 to 11 years. So if you are still watching me, you could have liked this video. For more such videos in future, consider liking, sharing with your friends, and consider subscribing to my channel. Thank you.